Hello, I'm Dr. Tim Chizmar, Maryland State EMS Medical Director. I want to start by thanking all of you for your dedicated service and thank you for inviting me to your virtual convention this year. I hope that we're able to join each other in person next year. The title of my talk this morning is Anaphylaxis When Minutes Count. In this talk, we'll discuss key points regarding recognition and treatment of the patient in acute anaphylaxis. Thank you again for joining me. So over the course of about the next half an hour, we'll talk about acute anaphylaxis and why timely recognition and treatment are so very important. We'll start out by understanding the scope of the problem, talking about the numbers of patients who may be affected, and then dive into a brief review of signs and symptoms of acute anaphylaxis and contrast that with routine allergic reaction. We'll also discuss timely and evidence-based management of anaphylaxis in the field. We'll also identify pearls and pitfalls in caring for anaphylaxis patients. So why do we bother to talk about this at all? Well, it turns out that about 50 million Americans have allergies. That's about 1 in 6 Americans, including 32 million who have food allergies and 10% of the world's population who has severe drug reactions. Maryland's EMS clinicians encountered over 5,000 patients with allergic reactions just in the past year alone. Most importantly, when treating a patient with acute anaphylaxis, minutes count, and our timely recognition and treatment of the patient can make a real difference in the patient's outcome. So one of the reasons I like talking about anaphylaxis is that I'm part of the problem. I have a peanut allergy myself, and I've had the unfortunate experience of having acute anaphylaxis more than once. Luckily, for those of us with allergic reactions, there are some therapies on the horizon, including oral immunotherapy, in which patients can be desensitized using small amounts that are given to the patient daily over the course of months. I would highlight that there are millions who have food allergies, including 1 in 13 children. Peanut allergy is among the most common in children and the most dangerous. This slide highlights some of the impact of acute anaphylaxis, including the fact that there are approximately 150 food allergy deaths per year, over 400 penicillin deaths in each year. And it highlights the most important point of my talk, which I hope you'll take away, which is make sure that the patient with acute anaphylaxis is receiving epinephrine first before we go to any other medication. So let's take a look at some of the common allergens. These include food, drugs, insect, and environmental allergies. Among the food allergies, the most common are milk, eggs, and peanuts in children. In adults, shellfish, peanuts, and tree nuts. Among the medications, about 10% of people are allergic to penicillin, while about 5% of people have an allergy to insects, including bee stings. And then there are sundry environmental allergies, including latex, pollen, mites, and pet dander. All told, these allergies represent about $18 billion in healthcare costs, and food allergies can represent up to $25 billion in healthcare costs just by themselves. So I'd like to start by taking a look at a case. You're dispatched to a 60-year-old male at a local elementary school. He reports that his throat just doesn't feel quite right, and he just threw up. But he wants to go back to his friend's birthday party in the classroom where they were having cake and cookies and a bunch of different desserts. So what else might you want to know? We'll take a look and we'll revisit this case towards the end of the talk, but I'll urge you to think about anaphylaxis early. So here's a question. What makes anaphylaxis any different from any run-of-the-mill allergic reaction? Well, anaphylaxis is broadly defined as a severe, life-threatening allergic reaction with at least 2 out of the 4 systems involved, particularly the cardiac and respiratory systems. So if the patient is exposed to a trigger or an allergen and has a low blood pressure or reports respiratory distress or respiratory symptoms, such as the throat feeling tight or their breathing feeling tight, we want to be thinking about anaphylaxis early on. Prompt recognition and treatment, again, can have a great impact on the patient's clinical course. We don't want to forget about the gastrointestinal or skin and mucous membrane systems as well. There are some patients who will present early on with just isolated nausea or vomiting when it turns out that they are just in the initial throes of having an early anaphylactic reaction. So let's take a little bit of a closer look at what I mean by cardiac, respiratory, GI, and skin and mucous membrane manifestations of anaphylaxis. The cardiac manifestations may include a fast heart rate, low blood pressure, or chest pain, Some patients may even pass out. From a respiratory standpoint, any wheezing, shortness of breath, or even just a persistent dry cough. Stridor, which is a very high-pitched noise when breathing in, is also a very worrisome sign. From a gastrointestinal standpoint, we don't typically think about this, but patients can present with isolated nausea and vomiting soon after they ingest an allergen. And importantly, skin and mucous membranes. So patients may present with flushing or hives or just isolated swelling of their lips and tongue, something we call angioedema. I like this picture because it shows it really nicely in the sense that you can get an appreciation for all of the different manifestations of anaphylaxis, really from the head all the way to the abdomen. So patients may present early on with just isolated swelling of the mucous membranes, their eyes, their lips, or tongue. This can progress onward to wheezing and respiratory symptoms. So importantly, when we arrive on scene, we may have been called very early on, and the patient may not have all of these things. They may just have one of these signs or symptoms. And it's incumbent upon us to be thinking that the patient's trajectory may go in a worrisome direction where they develop more of these symptoms and what we call a full-blown anaphylactic shock. So a little bit of a twist. Almost all of us think about allergic reactions as having a skin rash or hives or itching. But it turns out that about 10 to 20% of patients with anaphylaxis have no skin rash at all. So if there is a rash present, that would make us think of allergic reaction or anaphylaxis. However, if the skin rash is absent and you have other signs and symptoms with a trigger that's known to cause an allergic reaction, or something that's new, like a new food that a child has never ingested before, you should still be thinking about anaphylaxis early on. So on this slide, I want to take a look just from a broad standpoint as to what causes an allergic reaction to happen. So in order for an allergic reaction to occur, there's got to be an initial contact with an allergen, and in this case, the slide is showing pollen, but this could be substituted to be any food or medication, for instance. The body's B cells recognize that as foreign and produce antibodies to it, as you can see in step number 2 there. Step number 3, the antibodies are attached to the mast cell, and the mast cell is a type of cell that releases histamine. And we're all relatively familiar with histamine. We've taken antihistamines, particularly around the spring and the fall when we have seasonal allergies. Mast cells are loaded with histamine. So what happens in number 4 is when that allergen comes into contact with the body again, the mast cell, which is now preloaded and ready to go with antibodies on its surface, contacts that allergen, and that triggers a massive release of histamine and these other inflammatory mediators, things that cause swelling and cause the symptoms of an allergic reaction. Now, it's not entirely understood why some of us develop severe allergies and some of us don't. There are some theories behind it. So you may have heard the adage, rub a little bit of dirt in it when you're a child. That it's a good thing to have some infections while you're early on, that helps stimulate a healthy immune system. While I can't recommend that outwardly, I will say that these are factors that are associated with people developing fewer allergic reactions. So in order to understand, though, people that have more allergic reactions as opposed to people who have fewer, it's important to look at this thing called the T helper cell. And there are 2 main types, the T helper cell 1, that's shown on the left there, and the T helper cell 2. In general, people will have a balance of these 2, the T helper cell 1 and the T helper cell 2, but patients who have more allergic diseases, asthma and allergic reactions, tend to have a predominance of the second type of T helper cell 2. And T helper cell 2 people, T helper cell 2 predominant people, you can see some of the things that are associated with an imbalance or an oversupply of those Th2 cells, including widespread use of antibiotics, a Western lifestyle, and urban environments and certain diets. Those with a predominance of T helper cell 1 tend to have more protective immunity, but these are also associated with the development of autoimmune diseases. And again, these people in the T helper cell 1 group, where they have a predominance of T helper cell 1s, they are generally, in childhood, they've had early exposure to daycare, more viral infections, or more of a rural environment. So I like this slide because it shows sort of all of the manifestations of histamine. So we've talked about how an allergic reaction develops. We've talked about the endpoint that it releases histamine, but we've really not talked fully about what histamine does. Histamine does all of these things throughout the body. It causes the airways to constrict or get tighter. It causes your blood vessels to dilate or get larger, and that causes your blood pressure to drop. Also importantly, within the blood cells, it causes them to become more permeable and leak fluid into the surrounding tissues. As you can see, it also stimulates gastric acid secretion, which leads to the nausea and vomiting in some people as well. So histamine plays a central role. It produces a multitude of effects, including swelling and inflammation throughout the body. And again, this is just a picture of what anaphylaxis may look like. You see predominant swelling over the face, particularly around the eyes in many cases. Generally, you're going to see a fast heart rate and a low blood pressure. So as anaphylaxis progresses, it generally progresses to something that we call shock. And what is shock? So shock is broadly defined as inadequate blood flow to any of the body's organs or tissues. And there are several different types of shock, and we're familiar with treating patients with all of these different types of shock, particularly those with hemorrhagic or hypovolemic shock. Today we're going to focus our efforts on just looking at the recognition and treatment of anaphylactic shock, where we've got a new either medicine or food or some other allergen that the body is producing an abnormal response to. So this is a key point on this slide. We've talked a little bit about anaphylaxis, what it is, but what do we do about it? What is the first line treatment for a patient with anaphylaxis? What should we be reaching for first? Well, it would seem logical that if we just spent a lot of time talking about histamine and all the bad things that it does, maybe we should reach for an antihistamine, right? Well, as it turns out, the first-line medication for anaphylaxis is not an antihistamine, it's not Benadryl, it's epinephrine. And we have epinephrine supplied in a variety of forms, either vials or ampules, or the preloaded autoinjector, which we refer to as the EpiPen. But again, I want to emphasize a key point of this talk is to remember that epinephrine is the first-line medication for anaphylaxis. It's the epinephrine that is going to help reverse the effects of the anaphylactic reaction the quickest. So while antihistamines may block histamine, the epinephrine is going to act much quicker, and again, when minutes count, this is critically important. So what does epinephrine do, and why is it so important? Epinephrine constricts the blood vessels. It helps the body to maintain its perfusion and its blood pressure to all of the vital organs. It also helps open up the airways. It lets oxygen get in, lets carbon dioxide get out, and it prevents the blood vessels from leaking quite as much, which leads to that swelling around the eyes and the joints that I showed you on a couple of the prior slides. So most importantly, the takeaway point is that epinephrine is the first-line medication if you're thinking that the patient has anaphylaxis, and it rapidly reverses the symptoms within minutes. So again, the title of this talk is "At Minutes Count." So I wanted to just take you through a brief tour of the literature and look at a study of 164 fatalities due to anaphylaxis. So these are people that passed away due to an anaphylactic reaction. And their median time intervals between the onset of their symptoms and either cardiac or respiratory arrest. So as it turns out, it's anywhere from 5 to 30 minutes in this group of patients who passed away from anaphylaxis. On the low side from medical procedures, these are generally intravenous medications that were given. But you can see even patients with insect stings or food allergies, we've got minutes to act in order to make an impact on the patient's course and potentially save their lives. So all of you know I'm very excited about our new treatment protocols this year. These are two little snippets from our new protocol book looking at the adult and pediatric anaphylaxis protocol. As you can see, we felt that anaphylaxis was important enough that we gave it its own adult and pediatric page separate from the general allergic reaction pages. So this highlights, again, both the approach to adult and pediatric anaphylaxis, and I'll dive through this in great detail in the next few slides. Again, this is critically important that you both recognize and treat this early on so that the patient has an optimal outcome. So as we mentioned, the first-line treatment is epinephrine, and there are no absolute contraindications if the patient is truly having anaphylaxis. We always want to be cautious in patients who may be elderly or have a cardiac history. However, if the patient has anaphylaxis, epinephrine up to every 5 minutes for a total of 3 doses can be given prior to any medical consultation. For adults, the dose is 0.5 milligrams intramuscular if you're ALS or BLS drawing it up manually, or use of an epinephrine autoinjector, an adult EpiPen, which is 0.3 milligrams. And you can see, again, the pediatric dosing down there is laid out. Less than 5 years old, 0.15, or the pediatric autoinjector. For children that are 5 years and older, though, we up the dose to 0.5 milligrams if you're manually drawing that up, or the adult EpiPen, 0.3 milligrams. So again, after epinephrine, the next steps are ensuring a patent airway. The epinephrine will help you do that by reducing swelling and opening up the airways, as we mentioned before. But we want to add oxygen via face mask and ensure that the patient has a patent airway. In some cases, that may mean intubation or placement of an airway for ALS clinicians. We also want to think about positioning. So in general, if the patient doesn't have upper airway swelling yet, we would like to position them supine with their legs elevated, and this helps promote an improved blood pressure and improved perfusion to the head. If there is airway compromise, the patient's stridorous or they're struggling to breathe or they're telling you that their throat feels tight, you can allow them to remain upright. And just as we would with any patient who's vomiting, positioning the patient on their side or in a semi-recumbent position would be recommended. Pregnant patients in general, if we're concerned about their blood pressure, we'll try and position them on the left-hand side, and that will help bring some of the weight of the uterus off of the blood vessels to allow the blood to return to the heart a little more quickly. Again, that helps support the blood pressure. And then with all of these patients, we want to make sure that we have cardiac monitoring and continuous pulse ox to be able to assess whether the patient is improving or declining. So over the past year or so, we've de-emphasized fluid, but this is one case where we'd want to be a little bit more liberal with fluid, including lactated ringers, 20 ml per kilo bolus in general for adults or children who have blood pressures that are low. And you can see I've noted the blood pressures there. Systolic, we want to shoot for a systolic blood pressure greater than 90 in adults, and for children, a blood pressure that's greater than 70 plus 2 times their age in years. So for example, if we have a 2-year-old, we would want to shoot for a blood pressure of 74 millimeters of mercury or greater. Again, in addition, after the epinephrine, after we've established IV access, we can start albuterol. And this is new for BLS this year. We've always been able to give the patient's own prescribed inhaler, but many patients with allergic reaction may not have their own prescribed inhaler. So BLS and ALS alike can initiate albuterol. ALS can also initiate ipratropium. And you can see the dosing here, both for adults and for pediatrics. For young children who are under 2, we cut the doses in half. And then for patients that are under 1, we give just albuterol. So here's your antihistamine, but you'll notice that this is after we've addressed epinephrine. This is after we've addressed the airway. The dose for adults would be about 50 milligrams, either slow IV or IM, and 1 milligram per kilogram in pediatrics up to a maximum of 50 milligrams. Again, this is, I want to emphasize, after epinephrine and after the airway is addressed. And to top things off, dexamethasone or Decadron can be given by ALS. This is our steroid, which in general, which can be given by mouth, but again, in patients who are having anaphylaxis, we want to generally try to stick with either the IV or IO route in case they begin to have nausea, vomiting, or airway compromise. And you can see both the adult and pediatric doses there. Importantly, the steroid does help to reduce swelling and inflammation, but this does so on a very slow basis, and epinephrine, again, is the key drug to give if you think the patient's having anaphylaxis. For ALS clinicians, if the patient continues to have low blood pressure, continues to show signs of shock, paramedics may initiate an epinephrine infusion. They can do so by adding 1 milligram to a liter of LR, and then using the 60 ml drip set Start that at 1 ml per minute, which is 60 drops per minute. And again, these are for patients who are incredibly sick and continue to have low blood pressure despite us giving that intramuscular epinephrine up to 3 times. We increasingly see patients who are on beta blockers, for example metoprolol, and these patients may not respond to the epinephrine as quickly. While this is not in the Maryland Medical Protocol, I wanted to make you aware that you could consult for glucagon, which can help override some of the effects of the beta blocker. The dose would be, in general, 1 milligram every 5 minutes. Importantly, with glucagon, as many of you know, you want to be prepared for nausea and vomiting that can occur after the medication is given. So to revisit our case just a bit, as we're there in the school nurse's office, the 6-year-old boy who wants to go back to class and celebrate his friend's birthday party starts to wheeze a little bit. You put your stethoscope on and get a good assessment, and now he tells you he feels like his throat is starting to get tight. So what are we going to do? What's our first line med? What are we thinking now? Well, I hope after listening to me over these past several minutes that you're going to think about anaphylaxis and you're going to think about it early on. Again, our timely treatment with epinephrine when anaphylaxis has been recognized it can prevent further worsening of symptoms, complications, and death. But we've got to think of it early on. Just to take a look again to show you time to epi does matter. So looking at a couple of studies, only 14% of 164 patients who died from anaphylaxis received epinephrine prior to going into cardiac or respiratory arrest. After they went into arrest, several others, about 64%, eventually received some epinephrine. But again, this illustrates the importance of getting the epinephrine on board early if you think the patient may have anaphylaxis. Children who received epinephrine prior to arrival at the ED for a food allergy were also released from the ED far sooner, and they were less likely to require hospitalization. In the early group, only 17% required hospitalization, whereas those who received their first dose of epinephrine in the ED, 43% of those patients were hospitalized. Also, in the small study of 13 pediatric patients with food allergy, 6 out of 7 of the children who survived received epinephrine within the first 30 minutes. And unfortunately, 2 out of the 6 children who died received their epinephrine within the first hour. Again, this points to the fact that early epinephrine can save lives and reduce complications. Before we conclude, I want to touch on a topic called biphasic allergic reactions. Up to 20% of patients will have a biphasic reaction or a recurrent allergic reaction after the initial onset of their symptoms. So in these patients, we may treat them appropriately with epinephrine, antihistamines, albuterol, IV fluid, and they actually get better. But then at some point later on, they become worse again. They have recurrent symptoms. And this may occur within 48 hours of the initial reaction. It's often difficult to predict who and when for whom the reaction will occur and when it will occur. There are some that would speculate that this is associated with an initial severity of the reaction, so the patient with a more severe reaction is more likely to have a biphasic reaction, but again, that's not written in stone. Unfortunately, there's no evidence that the steroids that we give to try and prevent biphasic reactions actually work and lower the incidence of the biphasic reaction. But again, in patients who have allergic reactions, the steroid is generally helpful at bringing their swelling down. So we continue to give those regardless. The bottom line with this is that patients who are treated for allergic reaction, particularly acute anaphylaxis, should be observed. They should be transported. And if they are discharged, have easy access to epinephrine, rapid access to 911 and the EMS system if they have recurrent symptoms. So I'll conclude with a couple of take-home points. The number of patients out there with allergy and anaphylaxis are on the rise. We continue to see increasing numbers, and again, we've seen over 5,000 in the past year alone, just within the EMS system. For anaphylaxis, you should keep in mind that exposure to an allergen or potential allergen with either respiratory symptoms or a low blood pressure is enough to consider giving that epinephrine very early on. The other criteria would be having at least 2 out of the 4 major systems involved. So among the cardiac, respiratory, GI, or skin and mucous membrane systems, if you have at least 2 of those systems involved, you would want to consider epinephrine very early on. The first-line treatment, far and away, is epinephrine as soon as possible. As I've shown you through a couple of these slides demonstrating studies, patients not only survive, but experience a lesser risk of complication when they're given epinephrine early on. And again, all patients should be transported after an anaphylactic reaction occurs. This is important so that the patient can be observed, as many of these patients will eventually require multiple doses of epinephrine or multiple medications.
Hit the slide.
So in closing, I'd like to thank you for taking your time to view my presentation. I hope that you'll keep anaphylaxis in mind early on when you encounter these patients in the field. I know the past year has been particularly challenging, and I want to thank you again for your continued dedicated service. Again, I hope to join you in person next year.
California Casualty has been endorsed by the MSFA for 10 years for its auto, home, and renter's insurance. It is our honor and privilege to protect those who protect our communities. Happy 10-year anniversary to the members of MSFA. Thank you for all that you do. For more information about our program, please visit www.calcash.com/MSFA. We look forward to seeing you at various local, county, and state events.